Good morning. I'm Courtney Ladika. I'm from Pennsylvania. I did my training at Wake Forest University School of Medicine. And next year I'm going to be headed to, well, these upcoming months, I'm going to be headed to Northern California. So it's my pleasure to talk to you about a topic that I find quite interesting and I think is a very important topic. And that's medical marijuana, why it makes sense and the laws don't. So first, I do not have any conflicts of interest, not receiving any monies from anyone. But as I stated previously, I will be moving to Northern California, specifically Humboldt County, which is the second leading producer of legal medical marijuana. So this is most certainly something that I will encounter in my private practice. So what I hope to cover today during this talk is medical marijuana, who supports it, how it works, including the endocannabinoid system, its indications, toxicities associated with its use, its addictive potential, and its various routes of administration. So who's using marijuana? Recreationally, about 40% of U.S. citizens, U.S. people living here, age 12 and older, are using marijuana. This is greater in some places, probably California, and less in others, like Utah, most likely. And in 2009, this was the most widely abused recreational drug in the United States. There is some conflicting evidence as to whether now that's been overcome by prescription drug abuse, but still it's probably the leading drug abused. And this is, of course, much to the chagrin of the DARE program and Nancy Reagan's Just Say No campaign. As far as medical marijuana is concerned, here's a listing of the 12 medical marijuana states in 2009. Currently, there's 15 medical marijuana states, but as of 2009, these 12 medical marijuana states had a total of around 270,000 registered medical marijuana patients. Now, for each medical marijuana patient that was registered and was a card-carrying medical marijuana patient, there are likely many others at home that were using marijuana to treat their various ailments without their physicians knowing about it. Here's a map of the United States demonstrated in green the states that have medical marijuana legislation on the books. There are 15 states, including the District of Columbia, that currently allow for medical marijuana. The states in gray are those with pending legislation. This also hopefully demonstrates that medical marijuana is no longer a fringe concept, but is becoming more and more accepted in this country. So what about medical associations? My academy, the Academy of Family Physicians, is in support of medical marijuana, as is the internal medicine group, the American College of Physicians, along with the American Society of Addiction and the National Cancer Institute. Now, there are other organizations that are in support of medical marijuana, but I just listed the biggies. So what about public opinion? Public opinion is also largely supportive of medical marijuana. These polls were taken between 2005 and 2010. As you can see, there's somewhere between a 60 to 80% approval rating of the public. How about the presidential opinion? He's obviously our chief executive officer and he is bound by federal law. Medical marijuana is not permitted by federal law, but he has decided that it will not be a priority for his administration or for his prosecutors to go after patients or their physicians that are prescribing medical marijuana under the regulation of the states. Marijuana is currently considered a Schedule I drug under DEA's classification system. The DEA thinks that medical marijuana meets these three criteria: a high potential for abuse, no currently accepted medical use, and a lack of accepted safety. I hope to show to you throughout this presentation that I think all three of these statements are false. Marijuana is made up of at least 66 different cannabinoids, including THC and cannabidiol. You can see their molecular structure shown below. We have discovered in 1992 an endocannabinoid system. This is our body's endogenous marijuana system. Much like endorphins are our body's natural morphine, this endocannabinoid system is our body's natural cannabinoids. Anandamide, shown here, the molecular structure, is the natural ligand at the cannabinoid receptor. Through our studies, we found that the endocannabinoid system is responsible for things such as appetite, pain sensation, mood, memory, and immunity. The endocannabinoid system is a robust area of research. Since its discovery in 1992, there have been many articles, and just a quick search on PubMed, you'll see that there's 4,800 articles currently published on the endocannabinoid system. So there's a lot more to come in the future. The therapeutic indications that are most widely accepted for marijuana are neuropathic pain, chemotherapy-induced nausea and vomiting, AIDS wasting, multiple sclerosis and spasticity, glaucoma, and anti-tumor effects. I want to cover some studies, first on neuropathic pain. This was done in 2007 using HIV patients with associated sensory neuropathy. These patients both had subjective sensory neuropathy along with decreased ankle reflexes. 55 of them met inclusion criteria, and they were divided and allocated into two groups, smoked cannabis or smoked placebo. As you can see, 25 completed the study in each arm. These patients were asked to use a visual analog score, the top one, from 0 to 100 to rate their daily pain. I'll walk you through this slide. So, in the first 7 days prior to the intervention, these HIV patients with neuropathy rated their pain, and both the placebo group and the marijuana group had similar pain levels, somewhere around 60. So that's here. They were then brought into the hospital, but no intervention was done for these 2 days. There was a slight drop in pain scale for both of them. Then, while still in the hospital, they were given either smoked placebo or marijuana for this 5-day period, and again, rated their pain. This bottom line is the group that received marijuana, whereas this line is the group that received placebo. As you can see, there's a statistically significant decrease in pain in those receiving smoked marijuana versus placebo. This is a 7-day washout period where you can see that they both return to the same baseline. This is another important study that demonstrates the synergistic interaction of cannabis and opioid medications. This was done in a rat model of analgesia. Rats were placed on a surface that was gradually heated up until they flicked their tail. This tail flick was the analgesic threshold. These rats were given opioid medication and either vehicle, which was placebo, or THC. In this experiment, they gave incrementally increasing doses of opioids and did a dose-response curve. What they found is that the dose-response curve was shifted far to the left, indicated by these potency ratios, far to the left, with the rats that were given both opioid medication along with THC, with the exception of the last two. So what does this mean? It means that the rats were able to have adequate analgesic control with less narcotic when combined with marijuana. This is so important to our patients because there's such a large narcotic problem in this state and in this country. Any way that we as physicians can minimize the amount of narcotics that we are giving our patients, hopefully will reduce morbidity and mortality associated with narcotic medications. Toxicity. Marijuana has a low rate of toxicity. To date, there have been no substantiated deaths related solely to marijuana. The LD50 of marijuana, the lethal dose needed to kill 50% of subjects, is somewhere between 3,000 to 9,000 milligrams per kilogram. It is quite simply impossible to smoke or ingest that quantity of marijuana. in contrast to the sad statistics of narcotics in this country. I don't need to dwell on this. We've been covering this over the past 2 days. Pulmonary toxicity is probably the thing that comes most to mind when we think about adverse effects of marijuana. Marijuana smoke does contain many of the same substances as tobacco cigarettes. There's the same risk of pneumomediastinum and the same risk of pneumothorax as with other inhaled drugs. There's also an irritant bronchitis that can develop with marijuana. Let's look at marijuana and COPD. This study was done in 2009 by Juan using a large amount of subjects. These subjects were divided into 3 categories. Subjects that had COPD defined by spirometry, COPD defined by self-report, and COPD defined by self-report of physician diagnosis. And the 4 categories were non-smokers, marijuana only, tobacco only, and tobacco and marijuana. The non-smokers, obviously, in each category had no increased risk. The tobacco and marijuana smokers did have increased risk of COPD. The tobacco-only group had an increased risk of COPD, but the marijuana-only group, it's crossing 0, in all of these subsets showed no increased risk of COPD in the absence of tobacco. The American Thoracic Society also agrees with this, and in 2006 they presented a study by Tashkin that showed that people who smoke marijuana, even heavy long-term smokers, do not have an increased risk of lung, head, or neck cancers or COPD in the absence of tobacco. So it's marijuana and COPD. Smoking both marijuana and tobacco synergistically increases your risk of respiratory symptoms. We should be telling all of our patients that they should not be smoking cigarettes. We should particularly be telling our medical marijuana patients that they should not be smoking cigarettes. But smoking only marijuana was not associated with an increased risk of lung cancer or COPD in the absence of tobacco. Psychiatric toxicity. This has gotten a lot of press in the news lately, and there seem to be several studies that have comparable results. So this study by Arendt shows that cannabis may precipitate psychosis in patients already predisposed to schizophrenia, and it may also lead to an increased risk of persistent psychotic symptoms. Here's a study showing those studies by Arendt that shows the first age of incidence of a psychotic episode in those patients that were later diagnosed with schizophrenia. And as you can see, in both the male and female group, the cannabis group had a significantly lower age at first incidence of psychotic symptoms. But marijuana does not increase the overall incidence of schizophrenia. It just makes you younger at your time of diagnosis. So quickly, because I'm running out of time, marijuana is listed 11th on the addictive potential. This is after both over-the-counter and prescription drugs, including tobacco, opioids, barbiturates, alcohol, amphetamine. So I would just say that addiction should not be the reason that we say that marijuana is a Schedule I drug, because there's other medications with higher addiction potential that are able to be legally prescribed. Marijuana dependence is a problem. About somewhere between 1 to 17% of chronic users will become dependent on it. We need to be aware of that as providers. But I think the bottom line on toxicities is that all medications have side effects, and that includes marijuana, and we need to be aware of them. But the 1999 Institute of Medicine's report concluded that the side effects of cannabinoid drugs are within the acceptable risk associated with approved medications. Routes of administration, 4 different types: smoking, vaporizer, oral, and sublingual. Dronabinol and Nebuline are the 2 FDA-approved cannabinoid medications on the market. They're both Schedule III. Their active ingredient is THC, and their indications are as listed. They're not very widely prescribed, which I'll get into. Sativex is another up-and-coming drug that's legal in Spain and the United Kingdom. It's a 50-50 mixture of THC and cannabidiol, and it's an oral spray, sublingual. Not currently available, but in stage 3 trials. And dronabinol and Nebuline are thought to have poor side effect profile. Often people think they're more sedating, more intoxicating than pure marijuana. slow absorption, which I'll show you. It's difficult to self-titrate because of the slow absorption, and it's difficult to tolerate oral medications when you're acutely nauseated. So the onset of action of dronabinol is 30 to 60 minutes, Nebulon 60 to 90 minutes, Sativex 15 to 40 minutes. Let's contrast this to inhaled marijuana, where you're getting your peak effects in 1 to 2 minutes. These are different concentrations, 2.5, 6.0, and 9.4% THC. Your peak onset of action between 2 and 3 minutes. Imagine how important that is for our patients that are acutely nauseated or are having pain. Inhalation, I believe, is a more effective delivery system for THC than oral agents. It allows for near immediate results, self-titration based on puffing behavior, more control over dosing, and there's no oral tolerance requirement because it is not a pill. Are you opposed to smoking? Most of us are. We've kind of been raised that way. Smoking is bad. Well, there is an alternative. It's the vaporizer. Crude marijuana is placed inside of this machine. It's heated up to 120 to 170 degrees, and the cannabinoids are vaporized and then stored in this reservoir. You're not getting any of the products of combustion. And the plasma THC levels with smoked marijuana and vaporized marijuana appear to be similar, as shown on these graphs. So in conclusion, marijuana does have medical value. I believe it's misclassified as a Schedule I drug. It's relatively non-toxic, has a low addiction potential, and inhalation is an ideal route of administration. I'd like to finish with a quote by Ethan Nadelman. Our obligation, particularly as physicians, is to uproot our fear and actively fight for drug policies that are grounded in science, compassion, health, and human rights. Thank you, guys.